Perfect. Amazing. All right. Do you mind if I introduce you real quick?
Perfect. Be great, Eric. Thank you.
Perfect. All right, y'all. Well, thank you all for joining for tonight's Upper Sherman Graham Rounds. It's my distinct honor and pleasure to introduce one of my great mentors, somebody who sparked both my interest in shoulder surgery as well as doing really great research and making a difference through translating research into clinical practice. So, Dr. John Sperling doesn't need a lot of introduction, but genuinely somebody who has revolutionized the world of shoulder surgery, especially with regards to arthroplasty. Somebody who has led Mayo for many years and honestly led the world in how we sort of understand the anatomic, the reverse, and kind of all the considerations around this. Really honored to have him join us. I hope you all really enjoy it, and hopefully you get a chance to sort of really pick his brain afterwards because this is man knows more about shoulder
Ah,
arthroplasty than most can learn in generations and generations.
you're very kind, Eric. Well, thanks so much for the invitation again. For me, it's a real pleasure, and I think being a part of an academic teaching program, one of the great things for us is when you have the opportunity to train residents and fellows, and you see them step into an academic role, and you can see like Dr. Wagner, we're just so proud that he spent time with us at Mayo and is now passing on the knowledge that he has in such a terrific academic role. And Eric, it's phenomenal to watch what you've done with your career in this short time. So again, excited to be here, and I really appreciate you thinking of me to be a part of this. I think we'll go through a little bit. Eric, share some background about Mayo for some folks. Can you see the screen okay, Eric, or do I
Yeah.
need to adjust things? If I
No, it
need to
looks
adjust
perfect.
it,
No,
feel
it looks
free to
perfect.
let me know. Let me know. So this is what Rochester, Minnesota looked back in the 1860s, and it was a small town, as you can see. And what happened was a tornado came through and destroyed the city. And what ended up happening is Dr. William Mayo moved to Rochester after the tornado, and he brought his two sons with him. And what made Mayo unique, it was the first group practice in the United States where everyone had the opportunity to specialize in areas that they would prefer. And the motto of the Mayo Clinic carries on today, whereas the best interest of the patient is the only interest to be considered. So that's been the focus of the clinic since that time. This is the picture of the original Mayo Clinic building going back to the 1800s. You can see this is before the time of cars. You can see the horse and buggy there. And Mayo Clinic brothers understood the importance of traveling to learn new ideas and grow the practice. This is something that Dr. Wagner has done, that I've tried to do during my career, is to go visit people and see firsthand what they're doing in their practices. So I think that's one thing I would encourage the residents and fellows to be able to go see firsthand, travel, to be able to see practices worldwide. And this is a great quote by Dr. Charles Mayo, where he said, "The problem before us is to exchange information and to educate men through travel to develop a system of medicine which will combine the best elements to be found in all countries." And I was fortunate. I did two traveling fellowships. I did one in for 4 weeks in Europe, 8 different centers. And then I did another for 5 weeks, which included 3 weeks in the UK and 2 weeks in South Africa. And I learned a lot during those fellowships and was fortunate to bring that back to Mayo. One of the unique things we have at the Mayo Clinic is our total joint registry. And this was started by Dr. Coventry in 1968. And that was the year he did the first FDA approved total hip in the world. And he strongly believed in the importance of monitoring the outcome of replacement designs and understanding risk factors for failure. So, our Mayo Clinic registry, which Dr. Wagner and I were both fortunate to use, we actually have over 100,000 patients that are followed in this. We have 7 full-time staff with an annual budget over $1 million. And it's been a critical tool to understand the outcomes of specific joint replacement design. And I think what has made the Mayo Clinic registry so durable is that the actual cost of the registry comes out of the clinical practice every year. So very few people know this. So what we have is our budget for our department every year, $1 million comes out off the top for the joint registry. So it's not subject to fluctuations in research funding. So even during the financial crisis of 2008, nothing changed. Even during COVID, where all of us on staff, all of us took a salary cut, the total joint registry never took a cut in funding. So I think that's been one of the powerful things. And I think it's something for all of us to think about for all our research programs, how do we institute and get them set up in such a way that they're not subject to fluctuations in research funding? So the new thing, of course, now is AI and data analytics. So at Mayo, we have 5 data scientists in orthopedic surgery whose job every day is to look at the data that we have here. So one of the recent studies we did, 3,800 primary reverse, huge study, and we want to understand the risk factors for complications and the need for revision surgery. So what we found is that acromioscapular fractures occur on average about 8.5 months after surgery, more common in the acromion than scapula. But I think what we also found, and this is an area of debate, and I'll look forward to hearing Dr. Wagner's thoughts on this and others. If you actually look at the rate of acromioscapular fractures, they're higher with an inlay design compared to an onlay design. We also wanted to understand, well, what are the risk factors for failure? And we ain't got it. Current smokers, prior surgery, history of instability or non-union. But this was the interesting thing. You have a higher risk in Mayo Clinic if you get an inlay humerus or a medialized glenoid with your reverse. And what I would say is Dr. Wagner and I were out at the San Diego course. This is counter to where some of the market is going in implant design, but the data is very clear. If you want an implant that's got the lowest risk of failure, you go for an onlay humerus and a lateralized glenoid. Very interesting. That's been mirrored now in huge national registries. So when you look at New Zealand, Australia, and UK, it validates the Mayo data that an onlay reverse and a lateralized glenoid is the lowest revision rate at 10 years. So you may have data on your own, but the key is, can it be validated by external sources? And the Mayo data has in that regard. How about bone grafting? This is another interesting area. You look at the Mayo data, and Dr. Wagner was involved in this study. 20% failure of bone grafting when you do a revision reverse. And you look at the Rothman data, 25% failure, and Brad Edwards, 33%. So again, it's being validated elsewhere. And I think this is the nail in the coffin on bone grafting or reverse. So this is the study by Joe Zuckerman, 520 shoulders. Augments had superior outcome measures in every single area, every clinical outcome measure. And also, Joe's a smart guy. He looked at OR time, less blood loss, less notching, and 8-fold less revision. So very, very interesting now in terms of the trend going away from bone graft towards metal. And it'll be great during the discussion section. Again, there's no lack of controversy in shoulder surgery. It'll be great to hear Dr. Wagner's view. Is he more of a metal person, a bone graft person, or a little bit of both? Look forward to discussing that. This is another fascinating area, is thinking about, why do people need revision surgery? So we did a huge study. We looked at this 300 revision cases, and the rate of humeral component malposition is actually higher than glenoid malposition. This is not something we necessarily predicted, because a lot of us really focus on the glenoid side. So I think for us, we're going to think, if, boy, humeral component malposition has been underappreciated, as we think about new technology, the glenoid has been the primary focus, but I think it's going to be essential to think about both sides of the joint. So we were fortunate. We did the first robotic shoulder replacement at Mayo in 2024, and I think we've learned some opportunities for improvement. So what I'm going to do here, I'm going to do out of my stop sharing just for a minute. I'm going to pull up a video of actually one of the first robotic shoulder replacements we did at the Mayo Clinic, and we'll go through that with you. So Eric, while I'm getting that set, tell me your view now on bone grafting or non-bone grafting and where you're at with that.
Yeah, so I think I mean, in general, I think augments have changed the game in a lot of respects. So I think I and my partners here use augments a lot, metal augments a lot, for most cases. We just published our series on bone grafting when there's pretty significant, like in dysplasia, and have pretty good outcomes with it. I do think when you're bone grafting, you have to use a post. And I do think in the revision setting, bone grafting, custom implants, and and everything else is just challenging when you have those really bad uncontained defects. But no, I mean, bone grafting has a role, but at least in my mind and in my practice, but not. I use augments for most, and I think others on this call would have a similar sort of view on that.
How about custom components, Eric? How often are you using custom components these days, and when do you use them?
Yeah, not that often. I early on didn't have as much of success I would have liked with the glenoid, custom glenoids, and so
Tell me what problems did you have? Love to learn.
just so I had a couple that worked, and I had a couple had some kind of pretty early loosening that led to some pretty challenging salvage issues on the glenoid side, and so you sort of got a sour taste, I guess, if that makes sense from the from some of the from the commands. But I at the same time, admittedly, maybe didn't give it enough. You know, you have a couple failures. It's early on in your practice. It's hard to I don't know. It's easy to pivot, I guess. Maybe I pivoted
I
too soon.
I love your honesty, and that's one thing again I respect so much about you, Eric. And I have to tell you, you and I are in the same boat. So I've backed away from custom glenoids.
Yeah,
So actually now in my practice, I basically do almost none.
yeah, yeah. I
And
just
I think there's a number of problems with them, and it sort of used to drive. That's the nice thing of having a small setting like this. I can be as candid as I want to be with you, and
yeah,
I will tell you. First of all, that there are more difficult cases, particularly on the revision side, because you have no posterior wall to put a retractor on. The second thing is, it would sort of drive me crazy when people say it's so easy to snap it in like a Lego. That's not necessarily true.
yeah.
Trying to get those components in with minimal to no instrumentation, Eric, I found difficult. Getting the rotation correct, getting the fit correct. Love to hear your perspective.
Yeah, I agree. It's not near as smooth as you think. I had one that went really like super smooth, but I have to admit, the other ones I would agree with you. It's just like the fixation you're always like worried about, and yeah, it's I don't know. You're already dealing with such a difficult medialized glenoid. It's hard to get fixation. Truthfully, like yeah, I mean, like you said, it's interesting because it definitely is a shift right now. We just at these meetings as you kind of allude to San Diego and others that like people are talking and more companies are coming out with them. People, each company is coming out with their kind of own version of it. But it's gosh, I don't know. I'm not sure. I'm not sure if that's like the best at this point, at least in my mind. Like I agree with you. I think there's a futz factor. I think there's a fixation factor. You're already dealing with a lot of bone loss, and truthfully, and maybe I shouldn't say this. Maybe I won't say who, but a very good shoulder surgeon in our community had two like scapular spine fractures, like medial to the custom component, where it almost created like a scapulothoracic dissociation. And
Yep.
I'm following those patients because he sent them to me as a second opinion. And man, it's just like, what do you do about that? It's like, I don't know. It's a pretty hard problem. So
Did you have failures on your primaries and revisions both, or were they all revisions?
they were all revisions, admittedly, that I was doing this in. But but the problem was, I mean, they already were dealing with an uncontained defect, and then when they failed, it just became that much harder of a problem.
Okay, yeah, no, it's good. That's the nice having discussion like this. So I found the same thing, and I've not been using them,
Yeah,
and I think that what I found is that it's very difficult when you have no instrumentation and you're asked to put an implant in there with not little to no, but no instrumentation,
yeah,
and to make it work that way is very difficult.
yeah.
I think on the primary side it's different, but the revisions have been, I think, more difficult. So
I would agree.
I I like using augments, and I'll use augments and supplement them with bone graft. That's what I do.
Yeah,
The other aspect is that the way, and that's sort of a comment I made at the podium. I think we're in generation one of customs. I think they'll get better over time, and
sure.
as they get better, I'll use them more. But for now, I'm not satisfied. Right now, I think with an augment that I can dial, if you get a circular augment in whatever sizes you want, you can make almost anything work. And 99.9%, 99.5 you can make work. The problem with a custom component in 2025, it's either 0 or 100%.
Yeah.
So I had two where I got to the operating room and it wouldn't fit. So Sperling walked away with nothing, right?
Yeah.
So it's 100% or 0 with the custom, whereas an augment and bone graft, currently, you can make it work. So I remember you mentioned that in San Diego. That's why I wanted to ask it and bring it up tonight,
Yeah.
because I remember you were very candid and honest about your challenges with them,
Yeah.
and frankly, I've had the same problem.
Yeah. I mean,
So I appreciate that.
yeah, I was trying to, on the podium, Sperling, the reason I brought it up because, people were talking about all the different sort of versions of it. And I just wanted to get people's like true sense of like, is this actually what they're experiencing or is this just what they're saying?
And I've heard anecdotally, I've heard of other busy surgeons like you and I saying the same thing. I
Yeah.
think what's happened is that there's a couple people who use this all the time
Yeah.
who say it's easy.
Yeah.
And I think they're probably using it on Eric on cases that are not so severe.
Yeah.
Um, and it's just, I find the cases challenging. So I appreciate what you're saying. I've had the exact same experience. And essentially, I've not put one in now in over a year, year and a half. I've stopped using them in my practice.
Yeah.
That's currently now how strongly I feel about it, that I've actually stopped using them
That's awesome.
because of the problems.
Yeah.
Very interesting, isn't it?
It is. It's fascinating. That's
Yeah.
awesome to hear.
Yeah. So just I appreciate that. This is one of the first robotic cases I did, and this is just showing planning the case, going through that. Eric, give me your perspective now on technology and shoulder arthroplasty. What you're using and where you think we're going.
Yeah, I mean, this is such an exciting time to be a shoulder surgeon, right? Your the technology is like incredible. So I mean, we just finally the first true robot. I don't know if I consider the guidance as a true robot, but the first like true robot, as you know and as you did, has shown great success, and now more are coming on. I think pre-op planning is a must, as anybody who's here knows, and I think as you have taught me and you would agree and others, but in addition to that, now we're like starting to learn much better. Well, this you're showing a beautiful example of this, but learn much better how to actually take our plans into the operating room. And it's an exciting time between robotics, between improving guidance, between thinking about what the future is going to hold.
And this is just an example of putting the tracker on the humerus. So we went ahead. This is the first day that I did a robot last year, last April. I recorded it. And you can see here, we put the tracker on, we clamp it on the bicipital groove. Now we're going to register the landmarks on the humerus to correlate to what we saw in the CT scan. Some of the benefits of the robot is you can change your plan intraoperatively compared to a guide. I think the other thing is that that data was surprising, Eric. So 60% humeral component malposition, 50% glenoid. So the humerus really has been ignored. And as I'm sure your fellows know and residents, that the key to glenoid exposure starts on the humeral side. So if you don't have a good head cut, particularly if you make it too superficial, which that was the most common error, it makes the glenoid exposure more difficult. So you just get amplification of errors that happens. So this is just an example of using the robot to help with the humerus. And I also think we're in version 1 of the robot, Eric. I
Yeah.
think the next key things we're going to do to make it better is faster registration and improved reaming on the glenoid. Those are the two areas I think going forward what will change. The humerus has been good. I think the humeral cut's been very good. I think we can improve to make the speed of the registration. Tom DeQuinn, who's probably in my mind the sharpest guy when it comes to preoperative planning and technology, he's done well over 100 robots, more than I have. His increased OR time is only about 6 minutes a case. That's not bad at all.
Yeah.
So this is just going ahead, preparing the humerus for a reverse case down the arm. Eric, what are your thoughts now compared to MR guides and robotics? I think there's a race going on now. Which do you think is going to be the winner?
Yeah, I think I truly, I'm not sure. I think eventually, as you mentioned, we're early on in robots. I think the robots will get more efficient and accurate and smaller eventually. But I think MR also, I mean, you just look at around in the community and you see augmented reality and you see all the crazy stuff that people are doing. I mean, not, outside of medicine. And so I think AR is going to get that much better. And I truly actually think there'll be probably some sort of combination of AR
Okay.
and robots that probably will win out. But I do think both are so still, that's the exciting thing is both are still so much in its infancy.
And this is showing registry now on the glenoid side. So we did on the humeral side. Now we're going to go ahead and do on the glenoid side. We're going to pick our three areas. This is the anterior glenoid rim. Now we're going to do the glenoid face. And the last one we're going to do is the base of the coracoid. So the benefits of robotics or different technology is that we've already predetermined our entry point, inclination version, as well as depth control. So we can control all of those features. This is just showing bringing in the robot here in the reaming of the glenoid. And we've determined all those features. So we'll go ahead and ream the glenoid. Tom DeQuinn, again, another one of the Mayo family, did the fellowship with us. I know he and Eric are close friends. That Tom has very good data that shows if you use an augmented base plate on all your reverses, you save over 50% glenoid bone and you get 4.7 millimeters more lateralization. This is just preparing the augment to be able to go ahead and do that and controlling the rotation. Tom also has good data. If you get 5 degrees of malrotation, you leave a gap on either side and you lose over 50% contact. So having a way to prepare and place the augment in the identical rotation is helpful if you're going to use metal. And the goal is to preserve as much bone as possible. So this is just taking off a little bit of fibrous tissue off the top. You can see we keep all that hard cortical bone. That's really the goal. We really don't want to ream all that bone away and get to soft cancellous bone. And then we'll put the augment in, we'll pound this down, and then we'll go ahead and place the central screw and 4 peripheral screws. Eric, what's your sense on glenosphere sizing? When do you go for a bigger glenosphere in terms of diameter, lateralization? Tell me a little bit about your thoughts.
Yeah, first thing I want to say even before that, I was going to interrupt you, but you're showing such a beautiful video, I decided not to. I think all the fellows that are on this call, and even the ones that are not, you made a comment about the humerus preparation being key to glenoid exposure. Every single one of the fellows have memorized your 5 keys to glenoid exposure. They all do the super aggressive inferior capsule release on the humerus like you did. They all do the massive cuts and everything like that. So you should be
Ah,
complimented. Your 5 keys that as residents we
nice.
used to recite have been carried over down south. So
Thank you.
yes,
No, I
but
appreciate that.
nonetheless, yeah,
No,
nonetheless,
that's great to hear. And we all learn from each other, and it's great to hear that that's continuing on. And this is just a typical example of a reverse, and this is just one where we're not forcing in a super tight stem. We you can see I have some cancellous bone. It's not dead tight with cortical bone. We use an offset tray. We use the augment to create the tilt. We actually dial the glenosphere up, create space. So on a tight shoulder, you can do that. And we just need a few millimeters below the bottom part of the glenoid to do that. So what we're going to do is I'm going to stop sharing, go back to the presentation, and then Eric we'll go through another area which I think is interesting, and that for me is now the resurgence of anatomic shoulder, which I think you and I heard quite a bit about when we were in San Diego. So Eric, let's start it out. Get rid of all the crazy revisions you and I both do. In your average case, tell me percentage of anatomic versus reverse.
yeah, great point, Sperling. It's interesting because there is you and I know people who are just like doing reverses for everything, and some people like legit only do reverses, but it's wild looking at that. And we did this study in 2016 was the first year they're more reverse than anatomics, and I've here like nowadays it's almost like 5 or 6 times as many. So or nationally, but for my 2 cents, I for OAs I do majority of the people that have OA I do anatomics, with the exception of just very severe retroverted glenoids. And then I do have a busy, but I think all of us probably do, but we do have busy cuff practice. And as Sperling, I do lower traps. I get a lot of people sent for lower traps that aren't candidates for lower traps, and so therefore I do reverses on them. So I feel like I have probably a bias. So I think I'm around like 70-30 reverses versus anatomics. But truthfully, if you look at my OAs, vast majority of the OAs I do anatomics in.
All right, so I got to take advantage of being on the call with you tonight. This is good for me. So I want you to tell me so tomorrow when I'm in the R with my fellow, so I can get it directly from the horse's mouth. Tell me in your experience in 2025, and the fellows and residents on the call and your partners can keep you honest. Tell me now who are the candidates, the best candidates that I should send to my partners for a tissue transfer in 2025. So who are the ones that come into my clinic that you would say, based on 2025, in your thoughts now, on who is the ideal patient that I should send to my partner for tissue transfer?
Like for tendons for sure.
Yep. So
Uh,
tendon transfer. So non-arth. Let's do
yeah.
first a non-arthroplasty.
Yeah, so
So
clearly
somebody would say
non-arthritic. Clearly,
for a
so
cup.
for me, it's a
What would it
massive
be?
irreparable cough. It's somebody who has at least 60 degrees preserved elevation. It's somebody who is physiologically young and active, has certain sort of goals, and then at least in my mind, obviously has to have either easily repairable or intact subscap.
Okay.
Yeah. So I mean, I
So it
think it
has.
all depends on people's goals and how much they want to put into rehab and all of that stuff. We did it. We just published a study looking at lower trap versus reverse for massive irreparable cuff,
Yeah.
showing the scapulohumeral rhythm for the lower trap gets back to basically normal, about 2.5 to 2.8, and the reverse is your scapulohumeral rhythm is about 2 to 2.2. So you're still using more scapula than you are humerus. So I don't know if you're getting, although you're getting clinically, patient Broca measures were the same. So clinically, you're getting a very good shoulder with reverses. I do think you're getting a more natural motion in a reverse. And so the really active people, i.e., the people that do the yoga and et cetera, I do think maybe would benefit. But I mean, obviously, that could be debated as well.
Yeah, that's really interesting. So it's the non-repairable supra infra with a
Yeah.
repairable or intact subscap with
Yep.
minimal arthritis,
With
and they
no
can raise their arms
arthritis
60
and,
degrees.
and they have to have preserved elevation. For me, they have to have at least like 60 degrees preserved elevation. The two pseudo paralytics, I just think you should do a reverse on. So especially if they have
And
any hip escape.
and what is the distinction currently in 2025 in your mind between an SCR and a tendon transfer? And is there a
So
role in
look at the
2025?
read JS the current issue of JSES, Sperling. We just published this. So
Per,
we
I haven't read it yet. This is great.
yeah.
You're saving me some time. Give me the
Yeah,
highlights. This
hot
is
off the
great.
press, Sperling. We just published Emery's SCR versus lower trap across the board. And if you had muscle atrophy, so grade 2, 3, or 4 in the supra or infra, the SCRs did not do very well. The SCRs that didn't have muscle atrophy did pretty well as sort of an augment to repair. But when you had muscle atrophy, the lower trap's a lot better. So really, it had to do, at least in my mind, it has to do with if you have muscle atrophy or not.
Okay. And then in your practice, how often are you doing SCRs?
At this point, I've basically given rid of it because I'll try to repair the rotator cuff if they don't have atrophy. If they do have atrophy, then I'll do a partial repair plus a lower trap.
Okay.
One
Last
one thing
question,
before,
and then
like, if I could say different than Boston, I do think the partial repair is really important in lower traps. I think
okay.
it's like an additive effect. You get the partial repair to heal as much as you can, even if they have some atrophy, and then you do the lower trap on top of it to sort of give you an augmented effect instead of just trying to just do the tendon transfer and have that power everything. So.
I think that makes a lot of sense. And then the last question, and then I'll dive on, is balloons. Are there any balloons going on at Emory?
Gotcha.
Okay.
Go and take this one. We both of us have had mixed results, so I can say we
Yeah, essentially, it's in anyone who's too sick to undergo real surgery.
yeah. But truthfully, I don't know.
Okay.
Gotcha. What about you? I feel like I've had mixed results, so my enthusiasm has like tapered significantly.
Yeah, as I said, it's really essentially for anyone who's too sick to undergo major surgery because you can do them wide awake under just a little bit of sedation and a block.
Oh, really?
Yeah.
Oh, that's good to know. No, I appreciate that. That's really good to know. Good to know. Well, I'll dive in here. I think one thing that, and I'd encourage the fellows and the residents, if you can spend time with your attendings learning how to do a good anatomic total shoulder, it's a great thing to do. There's definitely, I think the pendulum is swinging back towards more anatomic. This started about 18 months ago. We were at the ASES meeting, and I think in San Diego, Eric, it was overwhelming. I mean, we had Jay Keener, who I think is just an incredibly bright, sober, clean thinker. Right? He's not overly enthusiastic on anything. I think he's very scientific, like yourself. He has made a push to go back towards doing more anatomic. Joaquin has, myself, and others. And I thought I'd share with you some of the things we've learned on our joint registry about the glenoid over time. With that, this was an interesting study. This was Tyler Fox. He did this study. This was some of the problems with an all poly glenoid design that we saw. They look great at 5 years and it sort of falls off a cliff. And the problem with this is you can see some of these are some of the all poly designs. And what ends up happening when they start to loosen, it turns into a windshield wiper or a pogo stick inside the shoulder. You lose all the bone out of the vault. So this is one I had to go ahead and reconstruct, sent to me. I dialed an augment in. This is something also interesting you'll note now when looking this up. So we actually don't over lateralize. We actually put the augment in the defect. Very interesting. So it actually is like when you put that augment in, if you look at the middle one, it's like an interference screw for an ACL. You're basically wedging the augment down the sides of the defect. So we're by no means trying to get the glenoid back to its normal or natural lateralization. We're playing the ball where it lies in golf, right? That's what we're trying to do. So it's a little bit of a different concept, Eric. And this is what I'm doing now when I'm doing revisions, not forcing excessive lateralization. So we're looking ours up. We're not done, Eric. Over 100 cases. And I've been rare, I would say in my life, in my practice, I'm rarely pleasantly surprised. In this study, I've been pleasantly surprised. I bet you our augments are working now over 90% of the time. And I think it's because, as Barlow said, we're not forcing too much lateralization. So here's a right shoulder. You can see we lost bone. Here's the left shoulder. And this is what it looks like. So it's an all poly design, and you can see how they bend, and you get that pogo stick phenomenon. So lots of different designs out there to try to do that. This is a design of an all poly with a hybrid fixation that we've used at Mayo. We have some data on this. This is one that I revised. You can see how the bone grows into the porous ingrowth metal. So I think a number of people have gone to porous ingrowth metal now because, again, the concept is we know bone is never going to grow into cement or polyethylene, but it can grow into porous ingrowth metal. So I think a little bit of metal is good. I don't like a fully metal back glenoid. There's some
Yeah.
other data out there that shows low rates of revision with hybrid fixation.
Sperling, can
But
I ask you? Do you mind if
yeah,
I
please.
interrupt you? Can I
I
ask
love
you?
it.
So, there's a lot of newfound enthusiasm for the metal back, and your institution, Mayo, or our institution, there was the one who put the nail in the coffin on the metal back early on, and then there's also this inlay glenoid that's starting to sort of catch on. What are your two thoughts on those two?
Yeah, I think the metal back glenoid's a bad idea. So I think a fully metal back glenoid has never worked. And the problem is you change the material properties of the poly against a fully metal back surface. Usually over lateralize the glenoid, which puts wear on there. And you're right, the data from Mayo on the metal back glenoid is very interesting. They look beautiful at 4 years, and like the all poly at 8 years, basically 90% of people were revised or died. So that's not good in life when your two options are either death or revision, right? So your death saved you from the revision or the other way backwards. So I think fully metal back glenoids are not a great idea. And I can tell you, Eric, I'm worried about these little insect button glenoids that are going in, and people leave them in quite a bit of retroversion. I've seen the head go back out the back still. And when those loosen, also, you get that pogo stick phenomenon inside the vault. So I've not been a big fan so far of seeing those. The other is I've seen people leaving those in really excessive retroversion where the head just goes right out the back. Well, I'd love to hear your thoughts on both of those.
No, I mean very similar to yours. The other thing I've seen with the inlays, there's a person in town that does some of the inlays, and I've seen multiple just terrible uncontained defects from the inlays punching out the posterior cortex when it fails,
Oh,
or posterior wall and it fails, and it creates this like terrible uncontained defect that's very hard to salvage.
interesting. Yeah. So I think, solving those problems. So I've not done that. When you do anatomic, are you using stemless or stemmed, Eric?
Stemless for vast majority, with the exception of some of the older patients with really poor bone. Stemless basically for everybody else.
Michael, how about for you? Stemless stems?
Yeah, so I think it depends, maybe slightly different than Eric's. I'd say my volume is probably about 20% anatomic, 80% reverse, but part of it's just the patient population I think that we get. The people that get anatomics are the primary when I'm lucky enough to get a primary arthritic patient, but a lot of them are like AVN from either
Yep.
transplants or sickle cell because we have a fairly large both of those. In those patients, I tend to use a stem because I'm worried about the ingrowth on the stemless and the AVN head. So we'll use a small, not a long stem, but essentially a short stemmed prosthesis.
Yeah, it's interesting. Yeah, I'm trying to do anatomics now. I think the reason is people have more of a forgotten shoulder, better internal rotation. I'm 56. When I'm in my early 70s, I hope I'm still fly fishing and playing golf. I'd rather have an anatomic than a reverse. And I think on the stem versus stemless, these are the reasons why a lot of surgeons like stemless for their patients. But I think as we broaden, think about that, implant stability is the key. And this is kind of something cool we started doing at Mayo in January. And we know that the humerus, or found out that, is highly asymmetric. So it's interesting. In the past, I think basically the companies, it's been easier for them to have one implant that can be used in the right and the left side. But the problem is that the proximal humerus is an asymmetric bone. We also know the best quality bone in the humerus is in the periphery. This is what it looks like. It's interesting. When you look at the top, it's like an iceberg, what lies beneath. And as you cut below the humeral surface, the humeral bone is absolutely asymmetric. So we've learned over time that if you want to engage that best quality peripheral bone, it needs to be asymmetric. And this is the problem with, particularly in people with poor bone quality, with the symmetric implant. You can see it can roll out of the bone. This is some of the testing we did at Mayo, and it's like an ice cream cone scooper. The ice cream can slide right out of the scooper. And when you get an asymmetric design, it's actually the implant, it's actually the strength limit of the foam bone. So it's pretty interesting. You can see when you do the testing, this is reverse engineering different designs. You look at the asymmetric design, it has more than triple the pullout strength, but you sort of get the sense of these two implants here that kind of look like that scoop of ice cream, and you get a sense why some of these are failing. What would make me nervous is when we go to some of the meetings now, some of our colleagues and friends are sort of advocating for these being done off label as reverse stemless, these implants. That kind of makes me a little bit nervous now in my practice. So that's not something I'm a big fan of. This is what it looks like. Probably the residents and fellows have not seen this. So you can see this is an asymmetric shape of the implant. It actually matches. So one fin goes down the dead center of the greater tuberosity, one down the center of the lesser, one true north. The other thing is all the different lengths of the fins are maximize their fixation into bone. So I'm going to show you a video of that. I think you guys like that. And then we'll be able to chat about a few things. Eric, love to hear in your practice. What do you think I should be doing with the bicep, the subscap these days? Are you doing a tenotomy, peel? What are you doing these days?
Anatomics, I do osteotomies. I like the bone-to-bone healing, but I realize that this is like talking about lack of evidence. So yeah, I do tenotomies because I like bone-to-bone healing. I assume you still do your tenotomies, so you like tendon healing.
Yeah, I'm still a tenotomy person, but again, no right or wrong way to do that.
Yeah.
I'll show you a video here. This is you see the video playing, Eric?
Yep.
Yeah. So this is an anatomic that I did, and this is an interesting one. So this is a patient that I'll get back here just for a second. This is a young woman with glenoid dysplasia. So her glenoid is in about 17 degrees of retroversion. She was born missing a lot of her glenoid, and then it creates a difficult problem. So for the residents, at least for me, I have a simple algorithm. My algorithm is 0 to 10 degrees high side ream, 11 to 24 augmented anatomic, more than 25 go to reverse. So this patient has 17 degrees of retroversion. We'll go ahead. We're going to plan this patient to have a augment. I have to admit, I was a late adopter to preoperative planning. I used to get CT scans, but I think the planning software really helps all of us now. So I agree with Dr. Wagner completely. I think it helps all of us in terms of that. And this is just looking at the different plan you can do on the head. On the glenoid side, I'm old school. I still like to get my glenoids back to neutral version. I find that if I cut the humerus in 30 degrees of retroversion and I put the glenoid in neutral, it tends to line up. So this is the problem without an augment. We only get 54% contact. You put an augment in there, we go from 54% up to 86. So that also helps us tension our posterior rotator cuff. So I like to use augments right in that sweet spot between 11 and 24 degrees. I think a simulated range of motion I take with a big grain of salt, right? The scapula is fixed. So I think it's interesting to see. I would say, Eric, this is the one interesting thing I could share for the fellows starting out in practice is how do you simplify your back table setup? So this is all I have on my back table. So every instrument on there I use, and there's no instrument on there that I don't use. So I don't know what it's like for you, Eric. If you show up at Mayo at like 3:30 in the afternoon, the second shift comes in, things are piled on top of each other. You can't find anything. So this is what it looks like, at least at 8 in the morning for me. So I think as the fellows are about to leave, which you are, make sure that you get from Michael and Eric what is their back table setup and preference cards. But it's nice just to think in your own mind, how do you drive efficiency? And this is how I drive efficiency. Very, very, very simple back table setup for a case. So that's what it typically looks like. We'll get guides for this case. The other thing that I'm a big believer in is hypotensive anesthesia. So I push our anesthesiologist still very, very hard on that. I know Dr. Wagner has gone over quite a bit to France and operated over there with Laurent Lafosse. I remember one day I went to his OR, Eric, and I couldn't believe how it was minimal bleeding, and he was running the blood pressure 70/40.
Yes.
And I wanted to talk to the anesthesiologist about it, but they weren't in the room.
Yes.
They leave patients unattended for 10 to 15 minutes at 70/40 and run 2 rooms.
Yes.
So low blood pressure helps. So you can see how medialized the head is. So there's the typical setup. Brown retractor laterally, knee retractor medially between the conjoint and subscap. I'm a tenotomy person, so I'm going to go ahead and take down through the tendon. And I do a big inferior capsule release. So the amount of the inferior capsule release is proportionate to the stiffness of the shoulder. The stiffer the shoulder, the bigger the inferior capsule release. So I'm right on the flat part of the humerus, big inferior capsule release, and I'm just cutting directly on bone, painting straight up and down vertically. Paint, 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 vertically straight up and down. And the way I do it is I tenadise the biceps high in the groove. So I put one stitch in the biceps high, I put one low, and then eventually I cut the biceps, but I leave it in there to reinforce my subscap repair on the way out. So I'm a big fan of using instrumentation. I know half the surgeons in the U.S. freehand cuts. I like to use instrumentation. We use an angel wing to make sure we're right above the rotator cuff insertion. We'll cut the humeral head. Now we're going to remove the osteophytes. So the more narrow the humerus, the easier the glenoid exposure. So as my mentor, Bob Cofield, taught me, whittle down the peg, make that narrow. So I do the humerus in a low beach chair, sit them straight up and down when you go to the glenoid. You get a better view, at least I do at Mayo. So what I'm going to do then is use this glenoid access retractor. This thing is awesome. It's got 2 prongs and a hole. A friend of mine showed me this retractor. The problem with the Fukuda is the head can pooch through the hole of the Fukuda. With this, the head does not pooch through the hole. So we're going to remove the labrum. We're going to remove the knee and put a Batman in the front and remove the rest of the labrum. We'll get a guide for this patient, and we're going to do an augment on this patient. Eric, tell me a little bit about your algorithm on managing glenoid bone loss on anatomics.
I just wanted to say one thing, Sperling. Everybody watching this that's worked with me is seeing a lot of similarities with regards to this glenoid exposure. It's
Good.
eerie. It's eerie, but the massive inferior capsule is one. They constantly ask me like, "Why can we see the glenoid so well?" I was like, "It's because John Sperling taught me to take off all the inferior capsule, and then voila, you have this magic, amazing view." So it
You're
looks
very
awesome.
kind.
So I love
No,
it. No,
you're very kind.
yeah, it's one I'm glad they're getting to see this. They literally your glenoid exposure, it shows since my time with you, we still basically do the same thing. So it's awesome. But as far
That's
as
good to hear.
manual bonus, your algorithm is basically the same as mine. Over 25, I get real nervous trying to push it for an anatomic, but I do love using augments because as you showed in that very elegantly in that plan, you can get really nice backside contact with augments.
And I think it's again working. And this one, as you can see, the dysplasia, it's kind of bizarre. Even though I sat the patient straight up and down, this glenoid is a little bit more oblique. And then we're going to go ahead and size this glenoid. We're going to go ahead and do a stemless for this patient. And this is just showing just this new technique we've been doing at Mayo. We'll put a planer on there, and then we'll go ahead and prep this for a stemless component. And I have to tell you, Eric, I was also not only a late adopter to planning, I was a late adopter to outpatient shoulder arthroplasty. So I was always one night in the hospital. And October 1st of last year, like flipping a switch, I switched to outpatient, and the patients have really liked it. So it's been a good thing. So we're going to go ahead and put our broach in. And then I think in the end, it's a soft tissue operation. So we're going to dial the head the exact amount and direction we want regard to the tuberosity for this patient. And I usually go up in diameter of the head before I go up in thickness. I probably use a larger humeral head than most people, but I think it's because of all the releases I do. And I'm usually looking for rolling motion. Does the head snap back? About 40% posterior translation. And this is kind of a cool one now. So rather than a regular onlay stemless, I'm going to show you something a little different. This is an inlay stemless implant. So it's going to sit about 5 millimeters below the surface of the glenoid. So at some point, if this patient, a small woman, who there may be a role, I think, for her in the future, thinking if you did a reverse, maybe an inlay for her because of her size, this is already going to be teed up below the surface if I wanted to convert this over. So we'll tap the implant down. You'll see I'm below the surface there. We're going to dial the head a little bit more than A. So we're going to want this the exact amount and direction in regard to the tuberosity. And then we'll go ahead and tap the humeral head down. And then we'll go ahead and we'll close the rotator interval and subscap. Eric, do you still close the rotator interval? Do you not? What arm position do you do it in?
Yeah, that's great. The study that showed the importance of closing the rotator interval actually came from memory before I was here. One of the few shoulder studies, I think, that came from Emory before on shoulder arthritis before Gottschalk and I got here. But no, yeah, so I do, I close the rotator interval in neutral rotation. I don't worry about too much about limiting external rotation, and as you've shown, I think the most important thing is restoring that anterior force couple.
So
Um,
this is pushing it a little bit. So this patient has glenoid dysplasia, but you can see with the guide, we were still able to get an anatomic, and she's an active gal. You can see how the implant's below the bone surface. I'm a few millimeters above the tuberosity there, not too much with that. So, Eric, I'm going to stop with that. I rambled on here a lot, but I love the discussion we had during this time. And any happy to answer any questions from the fellows residents or your partners yourself.
Yeah, let's open up. So y'all, please take this time to ask Dr. Sperling whatever you want.
And then the only other thing I'd say is, like I said, I'd encourage all of you when you're done, there's a beautiful window of time. Typically, and I'd love to hear Dr. Wagner's perspective, your first probably 5 years in practice, 3 to 5 years to go visit surgeons. It's fantastic. It's actually the least expensive way to get educated, but it's also the most valuable. When you go and you spend a day in the operating room with the surgeon or clinic, you really get a sense of what their indications are, how do they manage their team, how do they run things. So I'd encourage everyone on here, if there are certain techniques or people you want to visit, it's also from an academic perspective. If anyone's interested in that, it's probably the best way to get your foot in the door in an academic perspective and really get to know people. Eric, your thoughts on that in terms of visiting? You've done a ton of that over time.
Oh yeah, it's incredible. You get to have real conversations with people. You get a real sense two cents into kind of how things really are for them and not. You get great insight into great stuff that you won't see on podiums and at presentations, into how they run stuff, and you make just awesome connections. So yeah, I mean, without question, I think it's and I think most people on this call sort of I think know at least my view on this, and the importance of traveling, the importance of visiting people. So I would totally agree with you, John.
Yep.
All right, so open up to questions.
Dr. Sperling, hi, I'm Joanne. I'm one of the fellows. Thank you for a fantastic talk. I really appreciate all your tips and tricks. And echoing Dr. Wagner, see a lot of the things that you have passed down to us through him. So thank you very much for that. I did have a question about the role of the pyocarbon hemi and what your thoughts are. It seemed like there's some people at San Diego Shoulder who are pushing it and like saying they're not doing anatomics at all anymore and only doing like pyrocarbon hemis, and some people who are still more conservative. I just love your thoughts and your experience with this.
Yeah, you must have been reading my mind, Joanne. So actually, I spent some time on the plane coming back from New York looking at this, and it's fascinating. I'll give you my candid view. I think that it's gotten pushed incredibly hard by industry, but when you actually look at the data is disappointing. So if you look at the data, one paper from France, actually Pascal's paper, has a 7% revision rate at 3 years. I think most of us would say that's probably unacceptable. But when you look at the conclusions of the paper, they say that they think it's perhaps a good solution. I would say in my practice, if I had almost 1 in 10 people coming back for revision at 3 years, I would not view that way. The second thing that's very powerful, there was a surgeon at the San Diego course, Joanne, who I had not met before, and he pulled out data from the Australian Joint Registry. It's crystal clear when you compare pyrocarbon to anatomic and reverse, pyrocarbon has the worst survivorship. Very interesting. The third aspect is the rate of glenoid erosion with that is still substantial. It does not go away. The term now that has been rephrased rather than glenoid erosion is you get quote unquote recentering of the humeral head with pyrocarbon, which is glenoid erosion. So my own sense is that the Australian registry data looks poor. The data from Europe looks poor. Glenoid erosion continues, high rate of overstuffing, and the Ascend Flex stem has a terrible track record. So I think there's probably 5 reasons to avoid it. But if you talk to my fellows who got back from the recent course, I think pyrocarbon could have cured polio. So maybe a little aggressive, Eric, but it was in San Diego, it was a little over the top how hard it was being pushed. And now I'm going to hear that you have 5 of those on your schedule for tomorrow, and I can remove my foot from my mouth, right? At this point.
I mean, Sperling, the cost of it is you lose money on it if you just start the case. I mean, the cost is prohibitive. So, I mean, for us, if we're using it, it's usually a very, very young person in a very exceptional situation that we're having to get approved for its use because of X, Y, and Z circumstance because the cost is so expensive. So I mean, and without question, the Simflex stem is one of the worst stems that's on the market. So, and you have the gap, so it becomes really hard to get your perfect circle correct because there's a gap. So, and I'm not someone who's used very many of them. I do think. I think there's a role, and I think it'll be better than the metal hemi, but I don't know if it'll ever like take over from anatomics. That doesn't really make sense, and people who say that are clearly biased by their involvement. And especially with anatomics getting better fixation on glenoids, that's eventually anatomics can get their market share, and then like things like alternate bearing surfaces like pyrocarbon we use, at least in my mind, in special circumstances, like
Yeah.
young patients, AVN, that type of thing.
Yeah, that makes a lot of sense. Yeah, it was amazing because Joanne's perspective, I think it's almost being pushed now. It's either reverse or pyrocarbon hemi.
Well, that's what Mark
And
Ross said, like Australia said, but you're right. You look at Pascal's data, you look at the data, it's just like it's not there yet, and especially with the options you have. I mean, Smith and Nephew just came out with their version, but like both the stems that you can put them on, neither of them are that great a stem. So like yeah, I don't know. It's something that'll be interesting to see, but it's not going to be wear free for one, and for two, people say it's going to replace the anatomic. No hemi has ever replaced a total joint. Like just name one joint that a hemi state replaced a total joint in. Like it
and
does.
even my partner, Joaquin Sanchez Tello is not a believer.
Yeah, yeah. I
Yeah,
mean,
very, very interesting. He's not a believer either.
yeah, it's so. I mean, we do have for disclosure though, we do have a big avian population with our sickle cell population, with our HIV
Yeah,
population here. So we have done them, but not that's basically I don't know. Gotcha. Have you ever done a hemi or a pyrocarbon for somebody
I
besides
have not done a
AVN?
pyrocarbon hemi. I do just a standalone hemi typically for the young sickle cell AVNers that,
yeah.
are maybe 20 something. I don't want to really, I'm like, look, I know at some point you're going to need a revision to this, but no, I'll do a hemi for them. But anyone that's like 40 and up or 45 and up, I'll do the glenoid side typically. But I mean,
Yep.
we've had some fairly young. I mean, we have some. I don't know what it is about Atlanta, whether it's just lack of control, but we have some very, very uncontrolled JRA patients, as well
Interesting.
as sickle cell patients that we see some pretty horrific
Oof.
shoulders.
Yeah, yeah. It sounds like you have a very young population, very challenging problem.
Yeah.
Very
Yeah.
challenging.
A good question, Joanne. You're right. At San Diego Shoulder, it was a very popular topic. Kind of surprisingly so, but very popular topic.
And it was amazing is there's probably 60% of people raised their hand, Joanne, when they've used it. It was like I couldn't believe it. I nearly fell out of my chair. Yeah, it was a
Yeah, I've actually yet to
Yeah.
put one in. I was waiting for Eric to tell me whether it's good or bad. I'm a fairly slow adopter, and then normally Eric has to drag me with him and be like, "Gotcha, why are you still doing this? Start doing this."
the other guy who's very interesting. So I emailed about it this weekend. Then I'll start is Peter Chalmers, and Peter is also unbelievably scientific. He's not a believer. It was very interesting. He sent me a long email. I asked him the question: Is Peter? He's so organized. He sends me all the data, every bullet point, and said exactly what I think you and Michael both said. Essentially, it's a hemiarthroplasty. Very, very interesting. Peter's perspective on it.
Yeah.
Joanne, you asked the question of the night. That was awesome. Thank you. Well, Eric, I won't hold you guys much longer. I know I rambled on for an hour.
So, yeah, so Sperling, where do you think, all right, 10 years from now, what is what are we going to be the most excited about in shoulder arthroplasty? Is it that the reverse is going to be that much better? We're going to come up with some magical, perfect way to get rid of coronal fractures or dislocation? Is it going to be the that robotics slash MR has taken over? Is it going to be that the anatomic has made a resurgence? So we found a really good way to get a great glenoid. Is it some alternate variant? Like what's 10 years from now in your prediction is going to be the thing that like everybody's talking about at a meeting like San Diego Shoulder?
Yeah, I think anatomic is going to be coming back strongly because I think now you're starting to go to the meetings and people are catching on to the two bad problems with reverse. We're having a devil of a time solving.
Yeah.
We're having a devil of a time solving scapular fractures like you just described in people, particularly medially, and the unstable reverse. So I'm doing the near circle with Eric Ricchetti, and that's our topic this year. And I'm going to tell you, it's a very difficult problem. So I think there's going to be a trend, Eric, to go back towards anatomic, and I don't know which technology is going to win to help us execute intraoperatively our component placement better. But if I had to bet, that was it. And that's where I think we'll be. How
Yeah.
about for you?
Yeah, I agree. I think we're going to see the pendulum swing with technology improving our glenoid fixation. And if you improve glenoid fixation, I think anatomics, still went out. It's actually interesting. And maybe actually in this, it's probably it's okay. I'd be curious your thoughts. And maybe this is a technical thing, or maybe it's a pathologic thing. So we did a study. So we've had, these dynamic X-rays that you've seen,
Yeah,
where it allows us to capture scapular rhythm. And so we looked at like a couple hundred reverses and a couple hundred anatomics. And I did it. The hypothesis of the study was that the scapulohumeral rhythm would be better for anatomics and reverses, and we did reverses with cuff with for OA. So we tried to sort of standardize groups as best we could. And the scapulohumeral rhythm for even though the patient outcome measures were a little bit better for anatomics and reverses, a little bit, not crazy, but just like a little bit, were statistically better, but not didn't meet the MCID.
okay.
The scapulohumeral rhythm was actually not better for anatomics than reverses, and that was against what I was
Really?
theorizing, and that was against what there's been a one other biplanar study that just had 10 patients in each, and it showed the anatomics had better scapular rhythm. But that was also the Grammont style reverses in that study. So I was surprised, and this is over a couple hundred. So this is like a large,
Yeah.
large number of patients. I was surprised that the anatomics didn't have better scapular rhythm than reverses. Like, what is your take on that? Is it because we're doing in these osteoarthritis, they're going to be just stiffer? Anyways, both of them improved from pre-op, but neither of them got back to what like 2.5 is the normal scapular rhythm for the most part, and both of them got to about I think it was 2.1, 2.2.
Yeah, it's really interesting. I'm surprised by that data too. I don't know if it can be improved with either prehab or better rehab
Yeah,
after the procedure. I don't
yeah,
know if that's an opportunity for it.
yeah.
Uh, do you believe in the concept of an anatomic reverse, Eric, or not? And maybe if you know,
I don't because I still think we're still trying to figure out soft tissue tension. We're still trying to figure out thing, and I don't think that by putting it higher and like realizing like Franco talks about, I don't think that like actually creates an anatomic reverse. Um, you know, I know he loves saying that because his design is so unique compared to everybody else's design, but I'm not sure that like makes a lot of sense to me, and I truly. haven't seen the evidence that like actually is real. Like besides theoretically making the deltoid look more normal, I haven't really seen the evidence that it actually makes the clinical outcomes better.
Yeah, I think that's what Joaquin and I think. And I can tell you anecdotally, just looking at the cases that have come across on the near circle, I think it leads to a higher rate of instability.
Yeah.
Yeah, a
And
lot of
also,
those
if
are
you think
unstable.
about it, the higher you put it, you're gonna be. And we have actually some really nice examples of patients that we've seen with the DDR where you can see it hitting the chromium as they rotate. You hit it impinging the chromium, and they have pain, and they have like they are complaining of pain. And you get a CT, you think they have a chromial spine fracture, and they don't. But then then you look at it, and it's like they're like literally like impinging on their chromium
Interesting.
and it's creating this like sort of like tuberosity type pain. So I mean, it is. And I actually had this great view of a guy who was doing internal rotation. You could see it kind of hitting and clunking. And then I got a clinical video of him doing it where he kind of brings it up, kind of unlocks his shoulder, and then brings it up like this because he's like impinging on their chromium on a verse that was done with the sort of anatomic concept in mind. So
Really
I really think that we have not figured out how to make a reverse a true anatomic, and reverse has overcome stuff. But I agree with you. I think if we can figure out glenoid fixation, which I think we are, man, anatomics really are better procedures. I still maintain the best anatomic is better than the best reverse, hands down.
Yep,
So
I agree. I agree.
cool. Any other questions, guys, or are we gonna let Dr. Sperling go enjoy his evening? All right, Dr. Sperling, thank you very much for your time. Wonderful, wonderful as usual. You are always incredible. I can't wait till your dinner at ASCS. I think it's smart to change from Academy given the
Yeah,
drop at the Academy. So that'll be really fun. But it was fun seeing you in San Diego too.
it was wonderful. We're super proud of you, Eric, everything you're doing down there at Emory, and I appreciate all the fellows and residents and staff being on tonight. Thank you so much.
All right, you take care.
Thank you.
Good night. Take care.